Ok, buenas noches a todos. Vamos a continuar hoy con las charlas. Hoy vamos a hablar de gastrostomía, gastroyeyunostomía y yeyunostomía radiológica percutánea. Un tema muy interesante. Thank you, Dr. Song. Please go ahead and start.
Yeah. Buenas noches. Hoy mi presentación es gastrostomía, gastroyeyunostomía, yeyunostomía radiológica percutánea. First, I'd like to review the overall concept. Percutaneous placed feeding tubes offer the best option for patients who require the long-term nutrition. You can see percutaneous gastrostomy and percutaneous gastroyeyunostomy and percutaneous yeyunostomy. Percutaneous radiologic tube replacement has lower complication rate than percutaneous endoscopic or surgical placement techniques.
En primer lugar, revisemos los conceptos generales. Las sondas de alimentación colocadas vía percutánea son la mejor opción para los pacientes que requieren nutrición a largo plazo. Aquí pueden ver imágenes de una gastrostomía, una gastroyeyunostomía y una yeyunostomía percutánea. La gastrostomía radiológica percutánea tiene tasas de complicaciones más bajas que la gastrostomía endoscópica percutánea o las técnicas quirúrgicas abiertas para la colocación.
Indications are nutritional support for patients with inadequate oral intake due to dysphagia, risk of aspiration or obstruction, and diversion of feedings from esophageal leaks caused by recent surgery or trauma, and decompression of gastroenteric content for jejunal feeding.
Las indicaciones son el apoyo nutricional para pacientes con ingesta oral inadecuada debido a disfagia, riesgo de broncoaspiración u obstrucción secundaria a estas lesiones. También la desviación de la alimentación por las fugas esofágicas causadas por cirugía reciente o trauma. Y por último, descompresión del contenido gastroentérico y o la necesidad de alimentación yeyunal.
Contraindications. Absolute contraindications are unsatisfactory anatomy, uncorrectable coagulopathy. Relative contraindications are prior gastric surgery and massive ascites, gastric or abdominal wall varices, neoplastic or infectious involvement of the gastric wall, severe gastroesophageal reflux, and the ventriculoperitoneal shunt.
Las contraindicaciones son las siguientes. Las contraindicaciones absolutas son una anatomía insatisfactoria o una coagulopatía incorregible. Las contraindicaciones relativas son la cirugía gástrica previa con distorsión anatómica, ascitis masiva, varices gástricas o de la pared abdominal debido a hipertensión portal, afectación neoplástica o infecciosa de la pared gástrica, reflujo gastroesofágico severo o derivación ventriculoperitoneal.
Here are technical steps in the procedure. Before I talk about this one, I'd like to ask several questions to Sophia and to Manuel. Do you do percutaneous tube placement? Sophia, do you do? Are you involved in the procedure?
Yes, we do radiological. It's more common for us, but we also do endoscopic.
Oh, which one do you prefer? Endoscopic?
Percutaneous one.
Why?
Yes.
Why?
I'm used to do it more often. So technically, we used to do it frequently. So okay. I like it.
What size of gastrostomy tube do you use?
It is a Dosomüller.
Yeah, what French is it?
10 French.
10 French.
Yes.
Just 10 French, right? Do you
Yes.
use the anchor? That
Yes,
is,
we use 2 anchor,
2 anchors.
not just 1. Yes.
Okay. Okay. Do you give any drugs for sedation for percutaneous drainage?
Yes.
So what kind of a drug do you use? Midazolam?
Propofol.
Oh, I see.
The anesthesiologist use propofol.
Okay. Manuel, what's your complication rates?
I would say that I don't have that many cases for the moment. I think probably we're around 20 cases that I've done since I arrived from Argentina. We've had 2 complications. Patients that for some reason had the dislocation of the catheter.
Okay.
They did not evolve well. I think they both died because one of them had a paralysis and he was in the ICU, and I think the ICU didn't suspect what happened. In the end, when the patient died, they took out the catheter and they sent him to the morgue. So even the pathologist said, well, I don't know if this was the cause because the catheter was outside. So if they would have left the catheter in, they could have said it was caused by this. But well, that was one case. And the other case I had, unfortunately, it was also a difficult case, and the patient, we used a different type of catheter, and in the end, it didn't work out, and it caused. And the odd thing is, both cases, the first 2-3 days, the patients were fine, no problem, and eventually something happened 2-3 days later, and well, so it's hard to say if it had to do completely with the procedure, but well, so those are the 2 cases we've had out of maybe 15, 20, but other than that, all the other patients, no problem at all.
Okay. Same question. What size of gastrostomy tube do you use?
We use, I try to do as thick as I can, as large French as I can. So the largest I can obtain here is 14 French. So I use.
Oh, 14. Okay. There is a cook, right?
Yeah. Sometimes it's a cook. Sometimes there's a argon, and they have a skater, and also cook has 14, and the skater has another 14. Yeah, those are the ones I use. Yeah, but of course it's a Dawson Mueller or a common pigtail. Yeah.
Okay. Sophia, did you have any complications?
The only complication I've seen is the obstruction of the catheter.
Okay.
But I haven't seen another one.
How many cases you have had for gastrostomy?
Of in general,
up to now, personally.
Personally, I think 5, 6, not so much.
Okay, thank you. And then I will continue. Regarding the technical steps, we use a nasogastric tube 12 hours before the procedure, and we routinely use glucagon or buscopan.
Ok, para repasar los pasos técnicos. Primero, utilizamos una sonda nasogástrica que se le coloca al paciente 12 horas antes del procedimiento para la descompresión gástrica, y colocamos previo al procedimiento por vía intravenosa glucagón o buscapina, que se puede utilizar para disminuir la peristalsis gástrica.
And here you can see we introduce guide wire through the mouth or through the nose is okay, but we prefer through the mouth. And then we introduce a catheter, 5 French catheters over the guide wire into the stomach, and then insufflate the air into the stomach by a catheter. And sometimes frontal and the lateral views are helpful to determine the gastric wall and colon. We usually do the procedure on lateral view because we can see the tenting when we puncture. Also, we can tell the distance from the abdominal wall to the frontal or frontal surface of the stomach.
Posteriormente insertamos un alambre guía de 0.035 pulgadas a través de la boca que llega al estómago, o a través de la nariz, disculpe, sí. y después pasamos un catéter 5 French que se introduce sobre el alambre guía hacia el estómago e insuflamos el estómago utilizando este catéter. Para la colocación, muchas veces usamos o la vista anterior o la lateral. Como pueden ver, la lateral es la que preferimos muchas veces, ya que permite ver la tienda de campaña, el efecto de tienda de campaña que se realiza cuando uno punza el estómago, y también permite ver la distancia de la pared abdominal al estómago.
Okay, and then regarding the puncture site, you know that the distal body of the stomach equidistant from the lesser curvature and greater curvature in the middle part. And then we use a 17 gauge needle with anchor and then puncture. So the puncture should be made with a brief, deliberate thrust so that not to push the wall. Here you can see, sometimes you can see the tent if you puncture it slowly.
Posteriormente, bueno, el sitio de punción que se elige es en el cuerpo distal del estómago, equidistante a las curvaturas menores y mayores para evitar lesiones arteriales. Y luego utilizamos una aguja de calibre 17 precargada con un sujetador en T para punzar. La punción debe ser con un empuje breve y deliberado para no empujar la pared hacia abajo. Como pueden ver aquí, se ve el efecto de tienda de campaña que se puede ocurrir.
Okay, here you can see we punctured the stomach, and then through the needle, we introduce a guide wire. Also here you can see anchor. Sophia, do you use anchor? You said that 2 anchors, right?
Yes, 2.
Okay, I'll ask you a question again. Manuel, you said that you don't use anchor, right?
Yes, unfortunately, I have not been able to obtain any company that would obtain the anchors, but we're very close to that. But yeah, so for the moment, I don't use anchors.
Okay, so my technique is similar to yours, or it's different?
Except for the fact that we use the nasogastric tube to insufflate. We don't, unless the patient has an obstruction of the upper gastrointestinal tract, and for example, that you can't put in the nasogastric tube, if the nursing staff can't place the tube before the procedure, then that's when I come and I use a guide wire. But if they can place a nasogastric or a nasojejunal tube in the stomach, we normally use that for inflating the stomach. But other than that, it's basically the same, yeah.
Okay. And then,
I'm sorry. I wanted to say that we do the same as Manuel. We use the nasogastric tube to inflate the stomach. Okay. Yes, the purpose of nasogastric tube placement is to drain any secretion from the patient, right? So we can use the nasogastric tube, but nasogastric tube, there is a big hole. That's why we changed the nasogastric tube with just a catheter, because it's better for the patient. It is just a 5 French, but anyway, it is okay. This is just our method. And also the intragastric position is confirmed by aspiration, or you can just inject the contrast medium. Here you can see contrast medium at the gastric fundus. And then we can advance the guide wire to make an anchor system here. Here you can see anchor, but we don't use this kind of net set. We use this one for infants, but for adults, the anchor is loaded in the 17th French needle. That's why we just push the anchor with a regular guide wire.
Bueno, una vez que tenemos para verificar la posición intragástrica, se confirma con aspiración de aire a la jeringa o con inyección de medio de contraste. Como pueden ver, ahí se visualiza medio de contraste en el estómago. Posteriormente utilizamos una guía de seguridad, la cual avanza y empuja el ancla al estómago. Esta imagen que ven ahí, blanca, ese es el introductor que se utiliza, pero solo en pacientes pediátricos, por lo que entiendo. Y una vez que ya el sujetador en T está dentro, se tira hacia atrás, se tracciona, permitiendo que el estómago se adhiera a la pared abdominal.
And then we can use facial dilators and then place the selected gastrostomy tube after facial dilation. And then we also do follow tubography routine 1 day after the procedure.
Posteriormente utilizamos dilatadores faciales progresivos para poder hacer el trayecto y luego, posterior a colocar el tubo, le hacemos una radiografía de seguimiento un día después al paciente.
Complications. Peritonitis is a rare but most serious major complication. And also hemorrhagic and population occur in less than 2% of cases.
En cuanto a las complicaciones, la mortalidad del procedimiento de los 30 días es menor al 5%. La peritonitis es una complicación rara, pero es la más seria. Y la hemorragia o la perforación ocurren en menos del 2% de los casos.
Regarding the post-procedure management, when the tube is leaking around the skin insertion site, if the patient has a balloon retention catheter, the balloon is likely ruptured. So you can instruct the patient to fix the catheter to the skin until arriving in IR for tube replacement. If the patient has a multi-side hole catheter, like a pigtail catheters, the side holes have backed into the tract.
En cuanto al manejo postoperatorio, importante mencionar que si el paciente tiene fuga periostomal en el sitio de la inserción, hay probablemente dos posibilidades. Si el paciente tiene un catéter de gastrostomía con balón, es probable que el balón sea roto, por lo que se le puede instruir al paciente que fije el catéter a la piel y que se presente en el hospital o en el servicio de radiología para reemplazar el tubo. Y la otra es si el paciente tiene un catéter con orificios múltiples laterales, posiblemente uno de los orificios se ha devuelto y está en el trayecto se ha como salido, y entonces es probable que uno de los orificios está en el trayecto, básicamente.
When the tube is clogged, this is from inadequately flushed pills or suboptimal flushing after use. So the catheter should be vigorously flushed. If the above is unsuccessful, the catheter should be exchanged.
En el caso de que el tubo se haya obstruido, lo que ocurre, esto es debido normalmente, ya que no se tritura adecuadamente pastillas o píldoras o que se le realiza un lavado subóptimo después del uso. Entonces, en estos casos, lo que se debe hacer es enjuagar el catéter vigorosamente. Y si lo anterior no tiene éxito, entonces, en estos casos, se debe cambiar el catéter.
Let's move on to the details. The number of anchoring devices from gastropexy varies from 1 device to 4. As Sophia mentioned, you use 2, but some people use 3 and 4. Theoretically, the greater number of anchors increases the fixation force for tube placement, but also increase the risk of bleeding or infection.
Pasemos a los detalles. En primer lugar, podemos hablar en la gastrostomía. El número de dispositivos de anclaje para la gastropexia varía según el set que se obtiene. Puede ser desde una ancla hasta 4 anclas. Como mencionó Sofía, ellos colocan 2. Teóricamente, un mayor número de anclajes aumenta la fuerza de la fijación para la colocación del tubo, pero también aumenta el riesgo de sangrado o infección.
In 2008, we reported our experience with percutaneous radiologic gastrostomy with one anchor technique in 248 procedures in 242 patients. The gastrostomy tube and gastroplasty, we used 10 to 16, usually 14 French. And a single anchor through the same needle puncture tract was used. And we cut the anchor's suture 1 to 2 weeks after the procedure in the last 156 patients because we found that the anchor caused some complications. So now we routinely cut the anchor 1 or 2 weeks after the procedure.
En el 2008 reportamos nuestra experiencia con la gastrostomía percutánea radiológica con la técnica de una ancla en 248 procedimientos en 242 pacientes. Como pueden ver, el catéter que se utilizó era un catéter de 10 a 16 French y se utilizó una sola ancla introducida a través de la misma zona de la punción de la aguja. Eventualmente cortábamos, a posterior al paciente número 156, comenzamos a cortar el ancla a la 1 o 2 semanas después del procedimiento, ya que encontramos que las anclas podían producir complicaciones.
Complications. 19.4%. This is quite high, but that is because we included from the first to the last cases. And then recently it is less than 19% because we had a learning curve. As for the major complications, peritonitis occurred in 5 patients. 1 of them needed emergency surgery. The other 4 patients were treated by antibiotics. Bleeding occurred in 4 patients. 2 of them needed embolization. And gastrocolic fistula is very rare, but we had 1 case. We removed the tube. And also we had some problem with the oozing. Dr. Manuel, do you have any patient with oozing? Or Sophia, do you have any patient with oozing?
Large amounts, no. We've had some patients that refer some small amount of maybe fibrin or purulent discharge around the tube, but that's normal. But I've never seen all the other patients I've had, I've never seen any case where they've had oozing of a lot of gastric material around the tube. No, I haven't had that.
Sophia?
Me neither. No, me neither. I haven't.
But in some patients, oozing is a really problem because not gastric food, but it is always wet and it can cause infection. And also the patient need goods, but they have to change it. So this is a picky problem. So in the case, we change the small catheter to large catheters, but in some patients, it does not work effectively because that is because of the gastric motility. If the motility is not good, the oozing is a problem. Okay.
Sí, ok. En cuanto a las tasas de complicaciones, la tasa general fue de 19.4%. Las complicaciones principales incluyeron peritonitis en 5 pacientes. 1 requirió una cirugía de emergencia y los demás manejaron con antibiótico terapia. Hemorragia ocurrió en 4 pacientes y 2 de ellos ocuparon embolización. Y una fístula gastrocólica ocurrió en un paciente, lo cual es muy raro, pero se manejó retirando el catéter y colocando una segunda gastrostomía. Y por último, el doctor mencionó acerca de la supuración o el oozing alrededor de la ostomía, lo cual es una situación incómoda para el paciente, ya que tienen que estar cambiando la gasa constantemente. Es incómodo para ellos y se mantiene húmedo la zona y aumenta el riesgo de infección.
Here is an example of technical failure with the peritonitis in a patient with esophageal cancer. Here you can see, this is a lateral view, this is AP view. The tip of the gastrostomy tube located in the gastric fundus and with its loop and anchor in the peritoneal space.
Este es un caso de una falla técnica que el paciente tuvo una peritonitis. Como pueden ver en la visión lateral, aquí se ve la punta del tubo de la gastrostomía que está situado en el estómago. Sin embargo, el asa y el ancla están a nivel del espacio peritoneal.
Here is another patient. In this patient with the migration of an anchor into the peritoneal space, resulting in peritonitis 5 days after gastrostomy, plain radiograph and abdominal CT shows the gastrostomy tube in the stomach and the anchor in the peritoneal cavity with fluid peritoneal because of the peritonitis.
Aquí hay otro ejemplo de migración de un ancla al espacio peritoneal, dando por resultado peritonitis 5 días después de una gastrostomía. Pueden ver en el TAC que el tubo está en el estómago, pero el ancla está en el espacio peritoneal y se puede ver que hay un montón de líquido y aire en el espacio peritoneal por la peritonitis que presentó el paciente.
Ankle disenlargement occurred in 11.6%. In 5 patients, the ankle was disconnected during the procedure. In 9 patients, it was released within a week. In 8 patients, it migrated into the peritoneal space. In 3 patients, it was expulsed through the tract. And so 4 of 10 major complications and 1 technical failure were directly related to the ankle disenlargement. That's why we decided to cut the ankle 1 or 2 weeks after gastrostomy tube placement.
Los desplazamientos del ancla ocurrieron en 25 pacientes, o el 11.6% de los casos. 5 anclas fueron desconectadas durante el procedimiento, 9 se soltaron al estómago o el intestino delgado en el plazo de 1 semana, 8 anclas migraron al espacio peritoneal y los otros 3 fueron expulsados a través del tracto de la gastrostomía. 4 de las 10 complicaciones importantes o mayores que tuvimos y una falla técnica fueron relacionados directamente con el desplazamiento del ancla. Por eso es que decidimos cambiar nuestra técnica y soltar el ancla 1 a 2 semanas posterior a la colocación.
In 2015, we reported our experience with PRG using a 21 gauge needle and a single anchor techniques in 12 pediatric patients. We used a 21 gauge SIBA needle and a 6 French nerve catheter. The other techniques, including dilatation and tube placement, are similar to that of patients.
En el 2015 informamos de nuestra experiencia con 12 pacientes pediátricos con gastrostomías percutáneas radiológicas. Para esto utilizamos una aguja Chiva 28G y la técnica de la ancla única. Utilizamos 150 a 200 mililitros de aire para insuflar el estómago. La diferencia entre esta técnica y la convencional fue que se utilizó una aguja Chiva de calibre 21 y un catéter NEF de 6 French para crear un solo trayecto.
You can see we inflated the stomach and then punctured the stomach with the use of a SIBA needle, that is 21 gauge needle. and then introduce the hair wire, very small guide wire into the stomach. And then after removal of the SIBA needle, we introduce the 6th French nerve catheter. And then we introduce the anchor through the nerve catheter. Here you can see the anchor here. And the other procedures, again, are similar to those for adult patients.
Esta diapositiva muestra los pasos técnicos. Después de la insuflación del estómago, se inserta una aguja chiva de 21 G, esta verde que está aquí, a través de la piel en el cuerpo del estómago, y se introduce una alambre guía, un microalambre al estómago. Después se retira la aguja chiva y el alambre guía se mantiene en el estómago y se avanza un catéter NEF de 6 French sobre el alambre guía hasta entrar al estómago. Posteriormente se pasa el ancla a través del NEF para ir con un alambre de guía convencional, y los pasos técnicos posterior son iguales a la colocación de la gastrostomía en un adulto.
Regarding the complications, it was higher than in adult patients, even though we had 12 patients, and major complications, 17%, and the minor complication, 25%.
En cuanto a las complicaciones en estos pacientes, sí fue mayor la tasa de complicaciones, hasta un 42%. Pueden ver las complicaciones mayores, hubo peritonitis, que se manejó con antibióticos y cambio de tubo, y en complicaciones menores hubo reflujo gastroesofágico.
Here is an example of peritonitis. Here you can see gastrostomy tube and anchor in the stomach, and also pneumoperitoneum and peritonitis. So we exchange the locking pigtail tube with the balloon tube on the combined endoscopy and fluoroscopic guidance 7 days after the procedure.
Aquí hay un ejemplo de una peritonitis en estos pacientes. Aquí pueden ver en esta imagen el ancla y el tubo de gastrostomía en el estómago, pero asocia un neumoperitoneo importante. Entonces procedimos a intercambiar el tubo tipo pigtail a un tubo de gastrostomía con balón, y esto se realizó bajo guía endoscópica y fluoroscópica combinada 7 días después del procedimiento.
Let's move on to the percutaneous radiologic gastroyeyunostomy. In patients with a history or risk of gastroesophageal reflux or aspiration, PRGJ is considered. PRGJ can be performed as an initial feeding tube placement or by converting a prior gastrostomy tube to a gastroyeyunostomy tube. The tip of PRGJ tube should be placed well beyond the ligament of trites, and the gastric port should be placed located within the stomach.
Me gustaría pasar a la gastroyeyunostomía percutánea radiológica. En pacientes con antecedentes o riesgo de reflujo o aspiración gastroesofágica, se considera la gastroyeyunostomía como la mejor opción. Se puede colocar como una opción inicial o puede colocarse posterior a convirtiéndolo de un tubo de gastrostomía previamente colocado. Es importante que la punta del tubo de la gastroyeyunostomía debe colocarse mucho más allá, más avanzado del ligamento de Treitz, y el puerto gástrico debe estar ubicado dentro de la luz del estómago.
We had a total of 29 patients with primary or conversion PRGJ. So 16 procedures were done as the primary, and 13 as the conversion PLGJ. The indications for feeding gastrostomy were aspiration pneumonia in 19 patients, and gastroesophageal reflux in 8 patients, and duodenal malignancy in 2 patients. 3 types of PLGJ tube were used, from 10 to 16.5 French.
En este caso, reportamos en el 2008 nuestra experiencia con las gastroyeyunostomías percutáneas primarias o convertidas. Fue un total de 29 pacientes. 16 se les colocó una gastroyeyunostomía primaria y 13 pacientes se les realizó una conversión de gastrostomía. Las indicaciones fueron neumonía por aspiración en 19 pacientes, reflujo gastroesofágico en 8 pacientes, malignidad duodenal en 2 pacientes. Y para este estudio se utilizaron 3 tipos de tubos de gastroyeyunostomía.
Here is an example. You can see we performed this one as the primary PLGJ. We introduced the PLGJ through the stomach into the proximal jejunum. And then here you can see the gastric port located within the stomach lumen. This is gastric port. And its tip in the proximal jejunum.
Aquí hay un ejemplo de una gastroyeyunostomía primaria en un paciente. Aquí se pueden ver cómo las partes del tubo, la parte gástrica se encuentra en el estómago y ven cómo avanzamos el tubo y la punta del tubo se encuentra bastante avanzado en el yeyuno.
Complications, 21%. It is similar to the gastrostomy. And then we didn't have major complications. As for the minor complications, we had 4 patients with tube clogging and 2 patients with tube dislodgement.
En cuanto a las complicaciones, la tasa de complicaciones fue similar a la de las gastrostomías, que fue en 21%. No tuvimos complicaciones mayores. Las complicaciones menores incluyeron la obstrucción del tubo en 4 pacientes o el desplazamiento.
Okay, I'd like to talk about the percutaneous radiologic jejunostomy. This is not popular, but this is not that difficult. The PRJ tube placement is indicated for patients with a history of chronic aspiration, gastrectomy. Some patient has gastrectomy. In the case, there is no alternative treatment, just the percutaneous jejunostomy. Or abdominal gastric position. Percutaneous function of the jejunum is more difficult than that of stomach because of the high morbidity and easy collapsibility of the jejunum. The technical success rate range between 85% and 95%.
Por último, me gustaría hablar de la yeyunostomía radiológica percutánea. La colocación del tubo de yeyunostomía está indicada en pacientes con antecedentes de aspiración crónica, pacientes que tienen una gastrectomía total o una posición gástrica normal. La posición percutánea del yeyuno es más difícil que la del estómago debido a su alta movilidad y su fácil colapsabilidad. El éxito técnico de la colocación de la yeyunostomía percutánea oscila entre el 85 al 95%.
We routinely use the coil catheter. You can understand how it is important in percutaneous jejunostomy. Manuel, Sophia, you know what the coil catheter is, right?
I do now, Dr. Song, and I really need to get one.
Yeah, we use this one when we place the stent. Anyway, we inflate the jejunal loop by injecting air through the catheter. Upon frontal and lateral fluoroscopy, the catheter tip is located in an air-filled proximal jejunal loop. I will explain. So this is a coil catheter from the stomach, and then jejunum, there's one loop here, and then further, there is another loop. There are two loops. As you know, there are multiple radiopaque marks at the end of the covered portion. So we can inject contrast medium through the tube with while the guide wire is in place. So you can see this is an oblique view, but lateral view, you can see that is the close to the anterior abdominal wall. This is a little bit far. That's why we can select this one, because it is close to the abdominal wall. And also we can count the number of radiopaque mark. Again, you can see this one, this is the distal part. So 1, 2, 3, 4. And then this is 4. So we check the 1, 2, 3, 4, 1, 2, 3, 4. And then we just target this part. And then introduce needle to punctuate. You can see that this is a small bowel.
Oh, thank you. Okay. En cuanto a los pasos técnicos de la yeyunostomía percutánea, rutinariamente usamos un catéter de bobina, un catéter con marcas radiopaca en la punta. Entonces pueden ver aquí la utilidad de este catéter en el procedimiento. Se pasa el alambre guía a través de la boca y se pasa el catéter de bobina hasta donde llegue, y se puede insuflar el asa yeyunal inyectando aire a través del catéter. Como pueden ver, se utiliza la fluoroscopía frontal y lateral. En la frontal, pues, se pueden ver los loops ahí, y en la lateral pueden ver cómo este loop, donde están las marcas radiopacas, es el asa más cercana a la piel. Entonces, utilizando el catéter, podemos pasar medio contraste, pintar el asa, sabemos que estamos ahí, y usando las marcas radiopacas, podemos usarlas como blanco para punzar directamente hacia esas marcas.
We use 21 French silver needle for yeyunostomy, as we did for pediatric patients. Also, we use NEF set. It is the same technique. Here you can see, and then we introduce and then tube through that one.
Entonces, la punción del yeyuno distendido se realiza con una aguja chiva calibre 21, y esto se realiza bajo guía fluoroscópica con la técnica de NEF, como se utiliza en otros casos. Como pueden ver, introducimos después el alambre guía y el tubo queda ahí colocado dentro del yeyuno.
So the indications for PRJ was a previous gastric surgery for malignancy, 30 patients, a lot, more than half. And the neurological disorders with aspiration in 10 patients, and esophagotracheal fissura in 9 patients, and malignant gastroduodenal obstruction in 2 patients. Actually, this is better than percutaneous gastroyeyunostomy, because percutaneous gastroyeyunostomy tube is quite long and small. That's why the clogging rate is high. And also sometimes there could be influenced by the gastric port. That's why percutaneous yeyunostomy is much better than gastroyeyunostomy in patient with esophagotracheal fissure.
Entonces intentamos o colocamos la yeyunostomía percutánea en 51 pacientes. Tenían cirugía gástrica anterior, desórdenes neurológicas con aspiración, fístula esófago-traqueal u obstrucciones gastroanales malignas. El tubo que se utiliza es un 14 French, y esto a veces es una razón por la cual la yeyunostomía es mejor que la gastroyeyunostomía, ya que la parte distal de alimentación de la gastroyeyunostomía es más fina y entonces tiende a obstruirse más. Eso es.
And here is an example with a total gastrectomy due to gastric cancer. You can see it passed just, this is a duodenum and then jejunum, here that. Again, there is a one loop and the two loop here. And on lateral view, also there are two. So you can decide which one is anterior, and you can adjust the distal end of the mark. And then we punctured. Here you can see we punctured with a SIVA needle and introduced a hair wire. And then after removal of the SIVA needle, we introduced a nap set, exactly like a pediatric patients. And then we dilate the track and place the tube in the same technique.
Aquí hay un ejemplo. Este paciente tenía una gastrectomía total. Como pueden ver, pasamos el alambre guía a través del intestino y hay un loop y otro loop del yeyuno. Cuando lo ponemos en la visión lateral, como se ve en esta imagen, pueden ver que ahí están las dos asas y uno puede escoger cuál de las dos asas quiere punzar y entonces uno lleva las marcas radiopacas del catéter ahí. Una vez que se escoge cuál se va a punzar, entonces se punza y se coloca el alambre guía que entra dentro del intestino y posteriormente colocamos el NEF adentro sin ningún problema. Pues avanzamos la guía y por último colocamos el catéter.
The number of functions ranged from 1 to 4, and procedure time from 7 to 29 minutes. It did not take a long time. Regarding the complications, 9.8%, less than gastrostomy, even though we had 51 patients. And as for the major complications, peritonitis occurred in 2 patients, which was controlled by antibiotics with the tube exchange to 16 French.
El promedio de punciones fue de 1.7 y estuvo entre el rango de 1 a 4. La peritonitis ocurrió en 2 pacientes solamente y la tasa de complicaciones, como pueden ver, fue menor inclusive que en los pacientes de gastrostomía. Los pacientes con peritonitis se manejaron con tratamiento antibióticos y con el intercambio a un tubo de mayor frenchaje.
Here is a complication, development of peritonitis 1 day after PRJ. Here you can see contrast study and abdominal CT 1 day after PRJ shows fluid and air fluid level and leakage of contrast medium. And we changed the 15 French pigtail tube to 16 French pigtail tube, and then inserted a drain tube. This is, here you can see, this is a drain tube into the peritoneal cavity. 1 week after drainage, you can see improvement of the peritonitis.
Aquí hay un ejemplo de una peritonitis que se desarrolló posterior a la colocación de una Yeyunostomía percutánea. Se pueden ver el estudio de contraste y el TAC abdominal que muestran al día después de la yeyunostomía, salida del medio de contraste y aire y un nivel hidroaéreo en el espacio peritoneal. Entonces el tratamiento fue que cambiamos el tubo por uno de 14 French a uno de 16 French. Además insertamos un catéter de drenaje en el espacio peritoneal para drenar el líquido. Y como pueden ver, aquí está el TAC una semana después, donde ya hay resolución del aire y del líquido intraabdominal.
Here are take-home messages. Percutaneous radiologic gastrostomy with one anchor technique is feasible. However, anchor dislodgements are relatively common, and these are related to major complications. primary and convergent percutaneous radiologic gastroyeyunostomy is an effective procedure for enteral feeding, as well as for preventing gastroesophageal reflux or aspiration pneumonia. Percutaneous radiologic yeyunostomy with the use of a 21 gauge needle and the single anchor technique seems to be safe and effective with a high technical success and low complication rates.
Aquí están entonces los mensajes para llevar a casa. Primero, la gastrostomía percutánea radiológica con técnica de un ancla es factible. Sin embargo, los desplazamientos del ancla son relativamente comunes y estos se relacionan con complicaciones importantes. Segundo, la gastroyeyunostomía percutánea radiológica primaria y su conversión es un procedimiento eficaz para la alimentación enteral, así como para prevenir neumonía de reflujo o por aspiración. Y tercero, la yeyunostomía percutánea radiológica con el uso de una aguja Chiva 21G y con técnica de una ancla parece ser segura y efectiva con alto éxito técnico y bajas tasas de complicación. When you insert the neph introducer into the jejunum, my observation always when I don't use the fastener, when I don't use the T fastener in the gastrectomy, the gastrostomy, is that when if I want to put in a bigger catheter, I can insufflate the stomach easily. So it'll push against the wall, so I can pull and I can push it. But with the intestine, you can't insufflate the intestine to make it like push up against the wall.
Okay.
So when you put in the needle, I understand, no problem, it's easy. And you put in the guide wire, but when you put in the neph, that might push a little bit the intestine wall.
Okay.
So I wonder, is there anything you do about that?
A good question. Sure. It can happen. So that's why even now, some doctors, they don't like to use anchor because anchor can cause complication. But even though we don't use anchor in gastrostomy, sometimes it can push, the dilate can push the stomach wall. It is same, but it is more severe in yeyunostomy because it's very thin. And then in the case, you can place the guide wire, long guide wire, to make a safe margin, like into the far distal part of the jejunum. And you can use a little bit steep guide wire, not flexible guide wire.
Yes.
If you use a flexible guide wire, it can make a kink every time. That's why regarding the yejunostomy, it's a good idea to use an anchor. But if the anchor is not available, you can use a safety margin for the guide wire.
Okay. And then do you cut the anchors of the yejunostomy too?
Routinely, 1 week after yejunostomy, because at the time we don't need the anchor anymore. Okay. Because the loop is there.
Okay. And
also, complications like peritonitis usually occur within 3 or 4 days.
Okay, so you use a loop catheter. You don't use a balloon catheter.
Both are available, but I personally like the loop catheter because I have used that one. But my colleague want to use balloon catheter. But sometimes the balloon can rupture. But anyway, you can decide whatever you want.
That's it. I also am very impressed with this case of yejunostomy that had peritonitis, that you were able to convince the surgeons not to operate the patient immediately, and you were able to exchange it and actually put a drainage, and that was your treatment. I'm surprised. I'm very impressed. I think because it was you. I think if it was me, I'd say no, surgery now. Well.
Okay, good.
I have a question. In case of using balloon dilation, balloon catheter, sorry, have you seen necrosis in those cases because of the balloon?
In stent placement, right?
Yeah, no, in Yeyunostomy.
Oh,
When you use
like
balloon catheter.
oh, balloon catheter. So yeah, a good question. So there is a balloon is not that hard; it's a soft. So I haven't seen any set like a necrosis, but it is possible. There is some report, even though it is rare. Probably, Manuel, you can answer the question. You have used the balloon tube, right? It can cause any
for dilating stents?
Because
No, for Yeyunostomy.
For Yeyunostomy, no, we have not used balloon for Yeyunostomy. No, we have not done that. I have not. I've mentioned I haven't done Yeyunostomy yet. Oh, okay, I understand.
But same mechanism.
For surgical, I understand, but like open Yeyunostomy, Sophia's done that. I've done that. But no, I've used balloon catheters. We use sometimes even Foley catheters, and no problem. Sophie, have you used that or not? Have you used that or not?
We have once a case that we used, but we had so many problems with that. We couldn't insufflate the balloon too much because of that. Yeah. And the patient was so complicated, so we couldn't use it.
I would say this, I think it's because Yeyunostomies, it's like open Yeyunostomies, surgical Yeyunostomies have a lot of morbidity. They have a lot of complications. It's not, I don't think it's just your problem. I think it's everywhere. No surgeon really likes Yeyunostomies because they tend to complicate very much. The balloon is difficult to use, and fixation to the abdominal wall is not so straightforward. Some people use the Witzel technique, which is like tunneling. Some people use the stem.
Yes.
They sometimes, if you're too aggressive and you put too deep sutures on the intestinal wall, it'll necrotize, and then you have a problem after. No, Yeyunostomies always have problems, I think, and that's what I've seen, at least in my small experience. I've seen a lot of complications. So that's why I sort of love the idea of a gastroyeyunostomy. But if percutaneous Yeyunostomy is an option, especially patients who don't have like a stomach, I think that's fantastic. I think I definitely have to get behind that. Yeah.
As I mentioned, I have not used the balloon Yeyunostomy tube, but some people use that. But the balloon, regarding the balloon Yeyunostomy, is not that big, it's small. It's just to prevent regurgitation, or just that's why there is enough space. It's snug, not tight.
Yes.
So probably that's why there's one. I remember I read on case report. Okay.
And I have one question. The coil catheter, and maybe because Dr. Lopera's here, I hope you're listening, Dr. Lopera. The coil catheter, in Spanish, we've translated as catéter de bobina, because I don't know how it's called exactly, and I think the translation that we've done, coil it can be translated as bobina. But Dr. Lopera, if you know a name for this product in Spanish that we're maybe wrong, so if you can clear it up, that would be great. If you say no, that's how you call it, then okay.
No, we call it in Spanish cola de cochino, right? Like a pigtail.
Oh no, but I'm talking about the one with the radio opaque marks.
No, that one, it doesn't exist. That's, I think, a catheter that Dr. Son invented, so it's not available for the market. So we don't have that catheter. It's not available. I don't think, at least in the US. That's a very good idea to have those markers, but we don't have that catheter in the US, at least, and I haven't seen it anywhere else. So I think that's your invention, right, Dr. Son?
Yes, it is very useful for GI intervention, as I mentioned.
Yes.
Yeah, we definitely have to get that here in America, because
a catheter is extremely useful because you can put a wire and then you can inject over the wire and come back injecting, mark the length of the stricture. You can use a great catheter, but we don't have it. What we have to use in our practice, use like long introduced sheets, but his catheter is much better.
And also for jejunostommy, you can target one radiopaque marker. That is
Yes. That actually, without the coil catheter, I'm wondering how can you do it without the coil catheter? I did see one. Yes, sir.
We do yejunostomies. We don't like yejunostomies percutaneous. Even percutaneous, we don't like it because there's a lot of complication. Most people don't like it. I do those once in a while, but they're very tricky because easily you can have a piece of bowel interpose between your target and your needle. So in a patient that is obese, you can actually cross a piece of intestine and cause small bowel obstruction. So what we've been doing lately is actually do a combined CT. You know what that is?
Yes, combined CT is useful. Sure.
Very useful. So what you do is you put a catheter, you inflate the intestine, and then you do a spin, and then you're sure you're not crossing anything. So that way it makes it much safer.
Yeah, that makes a lot of sense. I like that. The other thing I was going to ask is, I did see a report once about a patient that they did a esophageal and what they did was they used a balloon catheter. They inflated it into the esophagus, and with ultrasound, they would inflate. Using ultrasound guidance, they inflated the balloon so they would see the balloon inflate. So they punctured the balloon, and they would actually puncture the balloon. And they used once they punctured the balloon, they knew they were in the esophagus because the balloon was inside the esophagus. So that could be a technique that you could. I'm not sure, of course, I do know more than I do, but maybe you could advance the balloon catheter into the intestine, and then once you inflate it with contrast medium or with air, you can puncture the balloon.
There's actually there's a company that is working in that idea exactly. It's called the Puma. And actually, the idea is done by an intensivist that does procedures at bedside. So what they do is you put a balloon in the stomach, then you inflate the balloon, and then with ultrasound, you actually look at the balloon, and then there is a very strong magnet that you put on the skin of the patient. So the magnet will bring this balloon close to the intestine, to the abdominal wall. Then you will puncture this balloon under ultrasound guidance. And this system will loop the wire inside the balloon, right? And then you pull the balloon through the mouth of the patient. Now you have the wire through the mouth of the patient, and then you put the tube this way. So what they do, that's a very good idea. We had the device, but it's so cumbersome that we don't use it. But they're working on a system for yejunostomy. So what you will do is, you same idea you just said, you just pass the balloon distally into the jejunum, then you target this balloon, you poke it, and then you fix the wire inside the balloon, and then you have access through and through. So that's a great idea. People have done the same with a snare. So what you do is you go in the jejunum, you put a snare, poke the snare, and then you pull on the snare, and you have access through and through. So there are many ways to do it, but they're very tricky procedures.
Yeah. Well, I think it's a very interesting procedure because I've always mentioned to everybody, I can't do jejunostomies. If you have a stomach, I can probably put a catheter, but without the stomach, it's harder. So that's why I was reading about the esophageal jejunostomy. But if you can do a jejunostomy, that's great. Okay. So thank you, Dr. Lopera, for your participation. Thank you so much. It's a pleasure to have you here. Okay, so Dr. Song, I think that's it for today, huh?